Hi, everyone. Welcome to Pathophysiology, Chapter 7. This is Dr. Shields, and I want to go ahead and break these chapters up a little bit. Chapter 7, Innate Immunity, Inflammation, and, oops, that should be and, Wound Healing. So let's just start talking about the immune system. So the immune system is a collection of structures and processes within the body to protect against diseases or other potentially damaging foreign bodies. Functioning immune system is essential for survival. We actually have more bacterial cells in and on our body than we have human cells. So we have good bacteria that is very helpful to help fight any type of pathogens. Identifies a variety of threats, so our immune system can recognize viruses, bacteria, parasites. Our immune system helps to guard against disease, tissue damage. Immune cells are distributed through the body but are very concentrated in blood and lymph tissue. So think about where our lymphatics are, kind of around our neck and our ears, right around our mouth, because a lot of the pathogens enter our body through the orifices in our head. And so we have a lot of lymph nodes up in that area. And the immune system functions are defense. So they want to defense against invading organisms. So they kill and neutralize any invaders that come into the body that aren't supposed to be there. Clean up, they remove damaged tissue, remove damaged cells, destroy cancer cells, and surveillance, which identifies and destroys abnormal body cells. So they're always on the lookout for abnormal cells. So the immune system basically is a series of defense mechanisms, and they protect and they hunt and they destroy pathogens as they come into our body. Major components of the immune system, the lymph nodes, they're a collection of lymphocytes, and they're ready to attack when a pathogen enters the body. The spleen acts as a filter for pathogens. People do have accidents and their spleens could rupture, and they can live without a spleen. However, they do have to be real careful because their immune system is weakened. Bone marrow, it makes our blood cells. Lymphocytes, when we talk about lymphocytes, we're going to talk about two different types of lymphocytes, the B cells and the T cells. There's two types of lymphocytes. The B cells make antibodies, and the B cells that make the antibodies can attack the toxins and kill them. The T cells, we have two different types of T cells, the killer T cells and the helper T cells. So the killer T cells kills cells that are infected with pathogens or are damaged. And the helper T cells determines which immune responses the body makes to a particular pathogen. So the helper T cells help the killer cells. The thymus makes T cells, but our thymus gland, which is right here behind our breastbone, is bigger in children than it is in adults, and older people, theirs is just shriveled up. It just gets smaller and more useless as we get older. And then, of course, leukocytes, which are white blood cells. So why do we need an immune system? To protect us from any invader or pathogen. And a pathogen could be any foreign material that can cause diseases, viruses, bacteria, toxins, worms, fungi, any other parasites. So we're bombarded with billions of pathogens daily, and we don't even get sick. That's why we need an immune system. So any external threats, the bacteria and the viruses, pollution, even allergens, we need an immune system for that. And sometimes people get allergies because the immune system is having like a hypersensitive reaction to whatever this is that somebody's allergic to, which we'll talk about. Any type of internal threats like cancer, like cancer cells that are abnormal. When do we get an immune system? It starts to develop when we're in utero. We're not sure exactly when it kicks in, but your immune system is always working, and everyone has one unless they're born without one, but that's extremely, extremely rare. The immune system, we're going to go ahead and talk about how it works, and we're going to talk about 3 different layers: the first line of defense, a second line of defense, and a third line of defense. This chapter, we're going to talk about this first and second line, and then the next chapter we'll talk about more of an acquired immunity, which is our third line of defense, which is more the T cells and the B cells. So let's take a look at the first line of defense, which is basically barriers at the body surface. So just the barriers that we have, like our skin, it prevents entry of any type of pathogens. Mucous membranes, they trap dirt and microbes. Secretions, kind of the same thing. Saliva is antibacterial, has enzymes in it. Tears, reflexes, and just normal microbiome that we'll go ahead and talk about. If that doesn't work, then the second line of defense kicks in. Our second line of defense is innate, okay, meaning that we're born with it. We're born with this, and we're born with this. So these are innate, whereas our third line of defense, when we talk about our lymphocytes, those are acquired. We acquire those through our lifetime. Also, non-specific here, I kind of forgot to tell you this, non-specific basically means these line of defenses are not specific. So whether it's a bacteria or a virus or a helminth or something environmental, this happens with every single invader. Whereas this specific immunity, these T cells and B cells are specific to a pathogen. So for example, you have lymphocytes that are specific to a chickenpox virus. You have them that are specific to only the rhinovirus and things like that. So if you generally, when people get chickenpox once, they don't get them again, because that's just a virus that doesn't mutate. So our antibody that our body forms can always typically fight it off. Whereas these right here, non-specific. Okay. So first line of defense here, kind of what I talked about, some mechanical, chemical barriers, and also should have physical, because skin, mucous membrane, skin is a physical barrier, hydrochloric acid in our stomach, tears, saliva, cilia in our lungs, wax in our ears. And this is just a little picture of kind of what I'm talking about here. So a normal microbiome, this is kind of a topic that has become a little bit more popular. Body surfaces are colonized with a combination of bacteria and fungi that is unique to a particular location in that individual. So remember, I told you that we are bombarded, or we have billions of pathogens. We have more bacterial cells in our body than we do human cells. So we need these bacterial cells, and when they're in the place that they're supposed to be, they work great to help for the defense. But when they move to an area that they're not supposed to be, then we obviously get an infection. So for example, we have a lot of E. coli in our gut, and that's an important bacteria to be in our gut. But when the E. coli gets into the urinary tract system, an infection occurs. So we do need to have E. coli, but we don't need to have it in our urethra. These do not cause disease if the person's immune system is working, and if not, then an opportunistic infection can occur. So an example like of an opportunistic infection might be something like, if you get prolonged treatment with an antibiotic, that can alter this normal bacteria or this normal microbiome and lead to an overgrowth of pathogens like Candida, which is yeast, or it can lead to C. difficile, an overgrowth of C. difficile, which will cause like a pseudomembranitis colitis, which is a bacterial infection in the gut. Most of us have kind of seen that. Or if somebody doesn't have a working immune system, they're immune deficient, then sometimes a bacteria that's just living on us can penetrate and invade them, and they get an infection that they shouldn't have. For example, we don't see many fungal pneumonias, fungus in the lungs. So generally our lungs are able to fight that off very well. But if somebody becomes immunosuppressed, that's generally when we see maybe like a fungal pneumonia. And this is just a picture of just the normal bacteria. You certainly don't need to memorize this. You just can see there's just a different combination of different bacteria, like in the stomach. There's just a lot of H. pylori. In the vaginal area, there's a lot of lactobacillus. So just, it's just kind of interesting, but don't memorize that. So this is just another slide with opportunistic infections and kind of which ones are the most frequent. And again, this is not something I want you to memorize. I just want you to kind of see these. So even like a herpes zoster. So most of us have, the herpes zoster living in us. And then when our immune system becomes deficient or depleted, then there's a possibility that this can kind of overtake, and then we get a zoster. Same with tuberculosis. We shouldn't be getting tuberculosis. We should be able to fight it. Oral candidas, which is the yeast. Just a lot of different ones here. This is kind of hard to see. Opportunistic pathogens normally do not cause harm to the host. However, when the host's immune system becomes weak, they may cause the disease. Okay. Causes of opportunistic infections: people are just genetically predisposed. People who are taking certain medications like chemotherapy. So chemotherapy goes in and kills all the bad cancer cells. That's the purpose of it. But it doesn't discriminate. In the meantime, it kills a lot of other cells and blood cells, and hence protection is certainly diminished. Diseases like HIV and AIDS, which causes the T cells to be completely depleted, and hence they have a really poor immune system. And here's somebody who we see with the fungal infections in their lungs, like a fungal pneumonia generally is that this HIV patient. Bone marrow disease, again, the red blood cells are made, or all the blood cells, the white blood cells are made in the bone marrow. So if we don't have white blood cells being made in our bone marrow, we're going to be deficient of lymphocytes. And certainly pregnancy can cause a little bit of a weakening of the immune system. So the second line of defense now, remember I talked about this being non-specific and innate immunity. Non-specific, so this happens just when pathogens enter our body, and we're born with the second line of defense. First being the phagocytes, white blood cells that eat and destroy pathogens. So this occurs if a pathogen does enter our body, that maybe it got through our mouth and into our lungs or something, and just passed through. Our first line of defense failed. This is going to kick in next. The inflammatory process is part of the second line of defense. Our bodies respond to infection and injury with erythema, which is redness, edema, swelling, heat, and pain at the site of injury. So this is a vasodilatory response, and we get that response. Inflammation, like an inflammatory response, is a defense mechanism in the body. It's a good thing. This is something that we want to have. So the immune system recognizes pathogens and begins the healing process. Hence, we get in the inflammatory response. So something like inflammation and then pyrogens as well, kind of these two right here, they're signs of healing. So this is a good thing to get inflammation. Kind of a good example of this is if you think about getting a pimple. You get a pimple because maybe like a piece of dirt went into your pore. It just penetrated and the dirt got in there. And so you get a little response: redness, swelling, heat, pain in the site of injury. The white blood cells come and they eat and destroy the pathogens, the neutrophils being the first one to the site. We'll talk about that in a minute. And then they contribute to like that little pus, that little white pus that's on the, that can form in a pimple because of the neutrophils that come there. Pyrogens, they travel to the hypothalamus, responsible for temperature, and they produce a fever. because many bacteria and viruses don't like the heat. They can't live in the heat. So again, the body is showing signs of healing with increasing the temperature. Cytokines stop the spread of virus to new cells, and this includes the interferons and interleukins. And interferons, I was just kind of remember, like they interfere, like they kind of interfere, get in the way of spread of the virus. Kind of helps with that. And then the complement proteins enhance the action of antibodies. So they help, they assist, they're helpers of the antibodies and help to destroy the pathogens. Phagocytosis, the two most important phagocytes are the neutrophils and the macrophages. And macrophages, you can put right here, are the monocytes. So the neutrophils and the monocytes are the two most important phagocytic cells that we have that go around and eat up these pathogens. Phagocytosis is the primary role of a neutrophil and a monocyte right here. So kind of what I was saying earlier, like the neutrophils right here, they are a primary phagocyte, and in early inflammation, so the very first phagocyte that comes to the infection is a neutrophil. And like I kind of said in that example with the pimple, you kind of can, that breaks down the white blood cell. The neutrophil breaks down, you get that little bit of pus there. But this is the one that comes first. And then the macrophages, like the monocytes and the lymphocytes, they also come to the site of infection, but they come a little bit later. So the neutrophil is the first guy there. Inflammation, we've talked a little bit about, and this is just kind of a summary. The body's attempt to self-protect to remove harmful stimuli by beginning healing. Infection, wounds, and damaged tissue would not be able to heal without the inflammatory response. Chronic inflammation can eventually cause several diseases and conditions. We'll talk a little bit more about that as well. And you can kind of see how this, like a thorn, gets stuck into somebody, and kind of an injury, and then all of a sudden this inflammatory response occurs. See how swollen and warm and painful and red it gets, and here comes the neutrophils. They're the first cell to that site, and the body is starting the healing process there. So local and systemic effects of inflammation. So there's local effects and systemic effects. And remember, the local manifestations of acute inflammation is the capillary dilation, and we get the increased blood flow, and we get the swelling, and we get the pain and the warmth. And here they have increased capillary permeability, lead to the fluid leaking out, and that's where we get the swelling. Then the leukocyte moves to the site of injury, adheres to the endothelium, and we see that with local effects, like your pimple, like that picture with the thorn right there. And then systemic effects are fever, which is caused by the increased pyrogens, and leukocytes or leukocytosis, so increased leukocytes, which is an increase in the number of circulating white blood cells. So basically over about 11,000 for adults. During many infections, this leukocytosis may be accompanied by what we call a left shift. So circle that. So basically what a left shift is, this is just like a normal, when we talk like a normal curve, we have the white blood cells right here. These are neutrophils that are matured. And this is a neutrophil that is a baby, a little baby band. And generally when we have normal neutrophils, the mature ones, the ones that are in the bloodstream, right here, they just go to the site, and there's enough of them to go to the site. But sometimes when somebody has leukocytosis and it's accompanied by a left shift, What that means is more immature neutrophils. And I always think of bands. I think put baby band, the little baby neutrophils. They're not quite mature yet, and they're in the bone marrow. And these more immature neutrophils, or these bands, are now present in the blood in greater proportions. So not only do we have the segmented neutrophils, or the mature neutrophils, now we have high levels of these little baby bands. And when we see these bands in the blood in greater proportions, that's an indication of leukocytosis, which is an indication of an acute infection, and it's referred to as a leukocytosis with a shift to the left. So just more baby bands instead of the ones that I mean, they're all there, right? But what happens is the bone marrow says, here, take all these little babies, they're not mature yet, just dumps them into the bloodstream, and they run and try to help out, and that's an indication that it's an acute infection. Chronic inflammation, so acute versus chronic inflammation basically is based on the duration, and that chronic inflammation lasts about 2 weeks or longer. And the chronic inflammation may have been preceded by an acute event, like maybe somebody had a wound that got infected and it took more than 2 weeks for it to heal. Or maybe an acute response did not precede it. Maybe it was something like a neurological disease or cardiovascular disease or autoimmune cancer, rheumatoid, lupus, fibrosis. So it could be any of these right here. So again, these are acute. These are something that happens, and generally the inflammation goes down. But any of these can turn into chronic inflammation as well. The next part is wound healing. So the conclusion of inflammation is healing and repair. So the skin has to heal and repair. So there's some type of wound. We saw that thorn, that was little one. Maybe it's a bigger wound. Somebody has to get a tumor scooped out, or somebody gets a sore on their back or on their leg or something. So healing and repair. So wound healing occurs in 3 overlapping phases. And this is just a teeny little slide to kind of give you the picture, because your book talks a lot more about it. It's kind of interesting, especially if you see a lot of wounds. It's certainly something to read, but I just don't want to get too involved in it because there's just so much content to cover. But the 3 phases are, first, the inflammatory phase, which we talked about. And it begins when the wound develops, lasts for about 4 to 6 days, marked by edema, erythema, inflammation, and pain. We already know that. We've already talked about the inflammatory phase. Healing process has begun. That's the beginning. That's not a bad thing. Immune system works to prevent microbial colonization, that the microbes don't just sit here and colonize and live here. So hopefully we have a defense system, and we don't get a colonization here, which would cause somebody to have recurrent infections. Moves into the proliferative phase, which lasts another 4 to 24 days. Granulation tissue starts filling in the wound. So this granulation starts filling in. This is not a wound that is just like a little slice where, it just kind of can really kind of evenly go back together. So we have to have granulation to fill up the hole. Fibroblasts lay collagen in the wound bed, strengthening the new granulation tissue, because it's kind of like a little different color. It's a little weaker. Wound edges begin to contract. As they begin to contract, it kind of pulls these sides together. Epithelial cells migrate from the wound margins. And so we get epithelial cells. They start migrating, and you can see how this hole's getting filled up. Then the last phase, the maturation phase, is new tissue, and it can last 21 days to 2 years. It can take a long time for this new tissue to develop. Length of time depends on the patient, wound-related complicating factors, duration of wound, patient comorbidities, wound infection status, we could go on and on and on. The filled-in wound is covered and strengthened, and then we have a little different type of a tissue here. The granulation tissue isn't the same as the original tissue, and we see a little bit of a scar tissue generally, or a different color type of tissue that occurs, and that is new tissue. The last slide is dysfunctional wound healing, And this dysfunctional wound healing could occur at any of the 3 phases that we were talking about of healing. The first one, impaired collagen matrix assembly, and that's basically this right here, a keloid or a hypertrophic scar. So what happens is the collagen matrix just doesn't assemble properly and line up the way that it's supposed to. There's reasons for it. Some people are just genetically predisposed and they are a keloid formers. Nutrient deficiencies are another reason that that could be happening. So a keloid is a raised scar, and what happens with a keloid, it tends to kind of get bigger than what the boundaries of the wound are. So somebody could have like a little teeny dot and then they get this big giant keloid because it gets bigger and bigger than what the wound is. There's a greater incidence of keloid formation in Black patients versus white patients. Similar to the keloid is what we call a hypertrophic scar. It's also raised, and this is probably more of a hypertrophic scar here, and it stays in the boundary of the wound. So for example, this wound, this is a hypertrophic scar, this wound started here and ended here, and the scar is the same size as the wound, it's just big and raised and hypertrophic. The next one, impaired epithelialization. It doesn't heal, so they have a wound that just doesn't heal, and wounds that get what's it called? Debriding, debridement. It prolongs this impaired epithelialization, and sometimes what happens is there can be a wound, and as the granulation occurs, maybe they would get a debridement and it would pull any new epithelial cells off. Also, water, or not water, but normal saline is really the best thing to use, because normal saline with a moist environment, like a dressing soaked in normal saline, keeps this from sticking here. And then when this wound is taken out, it doesn't pull all the new tissue off. But things like peroxide and iodine, they inhibit rather than promote epithelial healing. So iodines and hydrogen peroxide, we put that on these dressings and pack them and stick them on these wounds, and it doesn't really allow for the epithelium to grow, and it can cause this impaired epithelialization. The next one is an impaired contraction, like something like this right here, and these are common in something like a burn wound, and it can cause a deformity. The scar just starts to tighten, and you can kind of see that scar got so tight she's not even able to extend her pinky finger right here. Physical therapy could be helpful. And the last one, a wound dehiscence right here. This is a dehiscence, and this is evisceration where the content is actually coming out of it, but a dehiscence right here. The wound pulls apart at the suture lines, and there's a greater chance of dehiscence in the first week after somebody gets suture. So see, you can see this is a sutured wound, and anything can cause it, like an infection. We've all seen that, an infection in the wounds, it starts the wound, causes the wound to dehiss. Maybe somebody strains and they kind of bust their stitches and it opens up. Obesity is a real problem when it comes to wound dehiscence. So obesity may cause it. If somebody has a dehisced wound, then prompt surgical attention is required. All right, I think I'm going to stop here, and we'll continue on Chapter 8. Thank you.